Hi everyone, I'm Dr. Catherine Palmarola from IVFMD South Miami. Welcome to the February 1st week on fertility, where we will be discussing the menstrual cycle. So I know it sounds pretty basic, but actually a more complete, better understanding of your menstrual cycle is critical to optimizing your natural fertility, as well as being able to identify when something might be wrong and when to seek evaluation. So we'll start out by just discussing some reproductive physiology and understanding how the normal menstrual cycle works, how to use this information to optimize fertility, and then some red flags that might indicate that you might need evaluation by a gynecologist or fertility provider. So starting out with some reproductive physiology, we'll head back to high school health, but hopefully give you a couple of more tips and information about the menstrual cycle. Which I think is fascinating. So, like many things in our body, a normal menstrual cycle starts in the brain. And it's actually a region called the hypothalamus that releases a hormone called gonadotropin releasing hormone. This hormone, GnRH, is a hormone that fluctuates throughout the day. Before puberty, this hormone is fairly dormant. So periods can be very irregular at the beginning of puberty because the GnRH fluctuations haven't yet established a normal rhythm. It's critical to have a regular rhythm of GnRH in order to have normal menstrual cycles. GnRH, or gonadotropin releasing hormone, is not something that we test regularly in the blood because it's a very difficult assay to perform. It's metabolized very quickly and therefore difficult to detect in the blood. However, GnRH in turn communicates from the hypothalamus. It travels and talks to another area of the brain, which is very critical to many hormone functions, something called the pituitary. And it's in the pituitary that FSH, or follicle stimulating hormone, and LH, luteinizing hormone, are produced. So many of you probably have heard of FSH and LH. These are hormones that we do regularly check in the fertility process and are critical to a better understanding of a woman's fertility. As an aside, there's actually one additional hormone that's emerging as a very critical function, even above GnRH and LH and FSH. This is called kisspeptin, and we're having emerging research that suggests that kisspeptin is actually a master hormone behind everything. But we're still kind of learning about this hormone. We don't regularly test for it at this time, but it is something exciting in the works that may in the future be critical to our understanding of fertility. So with regular GnRH fluctuations, it then communicates to the pituitary to release FSH and LH, and these are the two critical hormones that talk to the ovary and help the ovary to build follicles. So we often like to check hormone levels on the second or third day of the period. This is when we expect your hormone levels to be at their baseline and is the best time to check these levels in your blood, as well as perform an ultrasound to visualize the ovaries and count your number of small follicles. We ideally want to see FSH below the level of 10. Once you get above 10, this may indicate that you may be in the perimenopausal period. It's a sign that the ovary is not listening to your brain as well as it should be. The levels should be nice and low to indicate that there is good communication between the brain and the ovary. Your brain is functioning just fine, hopefully well into your 70s and 80s. But if the ovary stops functioning well, the brain will start to release more FSH and LH to try to get the ovary to listen and do something. So if the level starts to go above 10, we do get concerned that you're in the perimenopausal period. Once these levels go into the 20s, this is an indication of menopause. We never confirm menopause with one test alone. It would be repeated at least a month apart, but levels into the 20s indicate menopause. LH similarly should be it's often below the FSH value, but similarly it should be below 10. Levels above 15 to 20 indicate menopause. Interestingly, if your LH is higher than the FSH, This is commonly seen in patients with PCOS or polycystic ovary syndrome. While we're checking the FSH and LH values, we also check estradiol, which is a type of estrogen that is released from the ovaries. So at the beginning of your period, again, on cycle day 2 or 3, we ideally should see the estradiol levels below 70 to 80. Where does the estrogen come from? So again, it's coming from the ovaries, and specifically it's being produced by the small antral follicles within the ovaries. Antral follicles are what we can see on ultrasound as a reflection of your egg counts. We can't see eggs, they're microscopic, but they live within the antral follicles. Again, as an aside, it actually takes about 90 days for eggs to grow from their very early stages, primordial follicles, until the time when they ovulate. But they've already gone through a process of maturation and actually attrition for about 60 days before we can even see them as antral follicles on ultrasounds. So an antral follicle count is something that your provider will perform at the beginning of your menstrual cycle, day 2, day 3, to get a rough sense of egg counts. They will literally perform an ultrasound looking at your ovaries and count the small antral follicles, or which appear as black circles within your ovaries, to see roughly how many eggs you have. So estradiol is produced by the antral follicles. At the beginning of your period, we should not see any growing follicles. They should all be small or considered less than 10 millimeters in diameter. If the estrogen level is high at the beginning of your period, this may indicate that you've already started to grow a follicle. We can see this around the time as women are nearing or entering perimenopause, the time around menopause. Again, because of the miscommunication between the brain and the ovary, the ovary starts to try to overcompensate and may start to grow a follicle even when you're finishing your prior cycle. So a high estradiol level might suggest that you're growing a follicle. There's negative feedback between the estrogen and the FSH and LH. So your FSH and LH levels, if you have a high estrogen level, may be low, but this is kind of artificially low. In order to have a true interpretation of FSH and LH, the estrogen really should be below 70 to 80. Occasionally, we see mildly elevated estrogen levels, 90 to 100, in women with PCOS because they do have a higher estrogen state. So best time to check these levels, again, is at the beginning of your period when everything should be baseline. In response to the FSH and LH that's released by the brain, the ovary will start to grow follicles. Usually it's 1 follicle a month. Occasionally women can grow 2 follicles, and this is sometimes a cause of fraternal twins, but often it's 1 follicle. And that's because of communication that happens within the ovary to suppress additional follicle growth and focus on a single follicle. So in response to the FSH, primarily FSH or follicle stimulating hormone, one follicle will start to grow. This follicle will release estrogen. So as that follicle is growing, the estrogen levels will rise. It takes about 2 weeks for a follicle to mature until it's ready to be ovulated. Around the time of ovulation, we expect estrogen levels to be between 200 and 400. This, drastic rise in the estrogen actually communicates back to the brain and causes a surge in the LH hormone, or luteinizing hormone. This communication, again, between the ovary and the brain is critical to result in ovulation. So you may have heard of ovulation predictor kits. They're actually detecting levels of LH, detecting that surge, which causes ovulation. Now, ovulation sometimes is thought of as a burst, a bubble bursting. There's nothing that really pops. It's just a kind of disintegration of the wall around the follicle, and then the release of the fluid that the egg was living in, and the release of the egg. Once the egg is released, it's the job of the fallopian tube to pick up the egg, sweep it into the fallopian tube, and sweep it towards the uterus. After releasing the egg, the follicle actually changes its job completely, and now instead of producing estrogen supporting the egg, its role is to produce progesterone. Progesterone is critical to early pregnancy support, and it is something that we monitor very carefully in the fertility world. Healthy levels of progesterone are needed to support the early pregnancy. If the egg comes in contact with sperm, we would expect the pregnancy to occur within 24 hours. It's still within the fallopian tube at this time, and it takes about 5 to 6 days to travel into the uterus. Attachment to the uterus we expect to occur by the 7th day. So that's called implantation. Progesterone, we've been focusing on the ovary, but actually the ovary has been communicating to the uterus this entire time. Estrogen, in addition to supporting the growth of the egg, communicating back to the brain to help with ovulation, estrogen communicates with the uterus to help build up the lining of the uterus. It starts out very thin at the beginning of the period, often 3 or 4 millimeters, but by the time ovulation occurs, we expect to see a thickened endometrium. It has, the glands of the endometrium have developed and have lots of sugar within them in response to the estrogen. We would expect the lining of the uterus to be at least 7 millimeters in thickness between the two sides, but ideally even more. So after ovulation, now that the follicle that the egg was growing in is now producing progesterone, progesterone also communicates to the lining of the uterus, and it is critical to changing the structure and function of that lining in order to support pregnancy. So the lining of the uterus may actually contract slightly, become decreased in thickness, and it changes its appearance on ultrasound because now, instead of building up the lining, now the lining is secreting all of those nutrients that it was working hard to build. And these nutrients are critical, again, to supporting the early pregnancy, implantation of the pregnancy, and healthy nutrients getting to that early pregnancy. If pregnancy does not occur, and implantation does not occur by that 7th day, the corpus luteum, which was the old follicle that's now producing progesterone, starts to disintegrate. It goes from what's called a corpus luteum, which produced the progesterone, to now a corpus albicans, and it starts to kind of disintegrate and degrade. The progesterone levels drop, all of the hormone levels drop. This is often the time of the month where women may experience premenstrual syndrome, moodiness, bloating, as all these hormone levels are plummeting. In response to the plummeting hormones, this is what triggers the menstrual cycle to begin again, and you will start to get a period. So these are all of the functions that have to occur normally in order to have a regular menstrual cycle. It's quite remarkable. Everything has to happen pretty exactly in order to have normal periods as well as to get pregnant. So just some other facts about normal periods. We usually anticipate a period length, meaning from the first day of one period to the first day of your next period, to be approximately 28 days. That's the exact average. However, the normal range is considered to be 24 to 35 days. About 90% of women will have a period length within that time, and actually only 15% will have a 28-day period. The variation in length of the period actually comes from the time it takes to build the follicle. But after ovulation occurs, this should be pretty standardized. It's approximately 12 to 14 days after ovulation that you should expect a period. The mean duration of periods it's approximately 4 days plus or minus 2 days. Certainly 3 days or less of bleeding or more than 7 days of bleeding is considered to be abnormal. The exact amount of bleeding is always difficult to quantify. Classically, based on research studies, the average amount of bleeding is 80 milliliters, but exactly how to quantify that at home is unclear. My rule of thumb is that if you are bleeding through more than one pad an hour for more than 3 hours, that would be considered heavy bleeding. If you're typically, women have 2 to 4 days of heavy menses, but then it should taper off towards the end. So if you're having 7 days of extremely heavy bleeding, this may indicate that something else is going on. So how can we use this information to optimize fertility? First, it's critical to know when you are ovulating. Once the egg is released, it has 24 hours to meet up with sperm in order to initiate a pregnancy. After that 24 hours, the egg will disintegrate. Sperm, in contrast, can survive within the reproductive tract for up to 5 days on occasion. So the most critical time to have intercourse in order to optimize fertility is actually the week leading up to ovulation. So if you know when you ovulate, you can estimate when to start having intercourse in order to optimize fertility. We do actually have available ovulation kits over the counter at pharmacies. These are often in the form of, they almost look like pregnancy tests. They are little kits that you pee on a stick and it will tell you if you are ovulating or not. I absolutely recommend the more simple versions. I'm not supported by any company in particular, but many of my patients use Clear Blue, not Clear Blue Advanced. It has a smiley face or an empty circle. It doesn't have a blinking face, or sometimes there can be many confusing results, but a test that is positive and then negative I find to be most helpful. There's also kits where you have to interpret whether a line is present. This can lead to confusion as well if it's a light line versus a dark line. So I recommend using an ovulation kit that is either positive or negative very clearly. So I would recommend starting these kits about a week after your period starts or when you stop bleeding. Checking daily in the morning. This is often when the LH levels are highest. We typically recommend with a second urine sample. And often it should be negative, and then one morning it will turn positive, indicating that you're starting the LH surge and beginning ovulation. As long as intercourse occurs every other day in the week leading up to ovulation, and then when you have a positive test, having intercourse that night and the next night, this would ensure adequate amount of sperm to meet up with the egg. We interestingly don't recommend daily intercourse because this can deplete sperm numbers. If you started daily intercourse after stopping bleeding, there may not be enough sperm present on the best day when ovulation is occurring. So every other day ensures that the sperm have enough time to replete their numbers, have adequate concentration and movement for the big day when ovulation occurs. So again, checking ovulation kits is critical to knowing when you ovulate to have adequate sperm in the area, timing intercourse at the best possible moments. Additionally, I often ask patients, so what day are you ovulating and when do you get your next period? Again, this amount of time should be about 12 to 14 days. However, if it's significantly shorter, this may indicate that there's not enough progesterone to support that early pregnancy and periods are coming earlier. So this leads me into kind of what are the red flags, what to look out for, when should you be evaluated if something is off. So certainly if you're not having regular periods, this may indicate that you're not ovulating. Again, a lot of communication between the brain and the ovary has to occur in order to have a regular ovulation and a regular period. If you're skipping periods on a regular basis, they're 3 months apart, this is an indication that you might not be ovulating, and the bleeding that you're experiencing may just be hormone changes, withdrawal bleeds. So certainly that would be a reason to be evaluated. If you're using ovulation kits and you notice that either they're always positive the first day that you check and they continue to be positive, sometimes we can see this in PCOS, polycystic ovary syndrome, because the LH levels tend to be higher and are triggering a positive LH test. So I always ask, are you having a negative result and then it turns positive, to indicate that the LH kits are working for you. Similarly, if you're using these LH kits and they never turn positive, this would be a concern that you're not ovulating, and certainly a reason to seek evaluation. There are other methods to detect ovulation. Some women check their basal body temperature. I don't recommend this method as the best form of detecting ovulation because it actually happens too late. The temperature rise is subtle. It's about 1 degree Celsius, and it occurs after you ovulate. So if you're waiting for that temperature rise to time intercourse, you may be missing the best window. The ovulation kits are detecting the rise in LH in the urine, which actually occurs within 12 hours of ovulation. So after detecting that positive LH in the urine kit, ovulation can be expected within the next 12 hours, which gives you time to have intercourse, say, that night. If you notice that there's a very short period of time, less than 12 days, between when your LH kit ovulation is occurring and when you get your period, this would be an indication that your body might not be producing enough progesterone, or you have what's called maybe a luteal phase defect. This would certainly be a reason to seek evaluation, and it can be very treatable, often just with supplemental progesterone. If you're experiencing spotting before your period, it's very common to have spotting the first day of your period, but if you notice that you're having spotting for several days before your period, this similarly may indicate that you're not producing enough progesterone and could benefit from some progesterone supplements. If you're experiencing bleeding in the middle of periods, this may indicate that there is a polyp or fibroids that are causing bleeding in the middle of the period when we should not experience any bleeding. Some women comment on implantation bleeding, which occurs about a week after ovulation. This is not a proven scientific thing, but it is very common. Women may note a very tiny amount of bleeding around the time of ovulation. But if you're experiencing heavier bleeding in the middle of the period, immediately after you stop bleeding, this may indicate either a polyp or something else within the lining of the uterus, chronic endometritis, something that is causing irritation and inflammation and bleeding. Similarly, if you're having extremely heavy periods or very, very long periods, this may be an indication of fibroids or abnormalities within the uterus that are causing heavier than normal bleeding. Similarly, it may indicate that you have a bleeding disorder. Von Willebrand's factor is actually very common. Often this would result in very heavy periods since puberty, the very first period resulting in hemorrhage. But a reason to be evaluated to look into these things. And in contrast, if you're having very, very short periods or lighter periods than expected, this may indicate that the lining is not building like we would expect in response to the estrogen. This can be very difficult to treat, but we do have a couple of methods within the fertility world to help thicken that lining in order to support pregnancy better. So that kind of covers the most important parts of your menstrual cycle, how to use that information to optimize fertility, and red flags to look out for. I did have a couple of questions that came in, so I'll just address those now. One listener asked, how many days within the fertility window, when is best to have relations? Should it be daily or every other day? So we discussed this. If having daily intercourse can deplete sperm numbers by the time ovulation occurs, when we need sperm to be at its best potential. So I do recommend every other day for intercourse, and then once ovulation occurs, that night and the following night, in order to optimize sperm numbers for ovulation. Somebody else asked, can clots be normal in the period? And certainly clots can be normal. However, if they are excessive, persistent, again, if you're using more than one maxi pad per hour for more than 2 to 3 hours on a regular basis, if you're feeling dizzy because of the amount of bleeding that you're having, lightheaded, chest pain, difficulty breathing, this is certainly an indication that you are having too much bleeding, and definitely a reason to be evaluated. But occasional clots can be very normal on the heavier days of your period. So finally, one listener asked, or mentioned that they had a hysterosalpingogram a year ago, which demonstrated blocked fallopian tubes. However, she then conceived and had a miscarriage. So she asked, should she repeat the hysterosalpingogram? Is it possible to get pregnant naturally in her case? So certainly hysterosalpingograms, there are limitations to this study. The uterus is a big muscle, and in response to the dye that we use for hysterosalpingograms, sometimes this can trigger a spasm, which would result in blockage or proximal blockage of the fallopian tubes. So if this occurred during that study, if this patient remembers having an extremely uncomfortable study, it's possible that spasm occurred, resulting in blockage. Clearly, since she was able to get pregnant, a fallopian tube is open, at least one of them. So I absolutely would recommend repeating the hysterosalpingogram to confirm if there is blockage on both sides or just one side. The location of the blockage is critical. A proximal blockage or a blockage at the very beginning of the fallopian tube where it meets with the uterus is more suspicious for a spasm. And so it might be an open fallopian tube. Blockage at the mid portion or at the end is more likely to be true and unlikely to be caused by a spasm. But I do think it would be worthwhile to repeat that test to see if the fallopian tube, or at least one, is open, and natural conception would certainly be possible if we do have at least one fallopian tube. So I'm just going to see if there were any additional questions that came in. Otherwise, I think that looks like it is it. Thank you so much for joining me, and if you missed the majority of this talk, we'll post this on the Instagram Live TV under February 1st week on fertility. All right, I look forward to seeing you next month. Take care.